And this was a talk that I gave at CDA this year. I was one of 3 people speaking. Liz.
Really? I'll leave it then.
Right. I was going to say, Liz, you've already seen it, so grab lunch and head out. Heather's also seen it, and maybe Kathleen. So,
we can always learn.
Chris was going to talk a little bit about resilience, so I'll just focus on that, and then I'll build in some of the components that are embedded in this new chair that we received this year from CIHR. So I don't have any conflicts of interest, and if you're interested in reading or getting the documentation or the references for a lot of this, Allison, Brandy, myself published a review paper that came out this month that covers a lot of these topics and is pushing us in a new direction. So objective number 1 is to take a look at the past and see what we've done that we thought was brilliant, and then realize it wasn't, and say, what can we do in the future so that we don't look back at this moment in time and say, wow, we thought we were doing something really well, but we're actually missing a whole book. So here's a great example. I love cycling, so this is a Tour de France picture where guys are lighting up a cigarette before they get into the mountains. Why did they do that? Because they thought if you smoke a cigarette before you hit the mountains, it would open up your lungs, be able to breathe more deeply, and you get more oxygen, and you be a better cyclist. So we look back on that, and it's ridiculous. So take a look at what we're doing now. Are there any things that we're doing now that 10 years from now we might think are ridiculous? Here's another example, more frequent. Back in the 80s or 90s when I was a high school student, we thought we were cool, and we look back on that now.
Which one is you?
So this talk was focused on diabetes and what was happening in 1994. So the average cost of a new car was $12,000. 1 liter of gas was 51 cents. A movie ticket was $4, 12 eggs, 87 cents. 2 liter Coke was 95 cents, and cell phones, they didn't exist. I had a nice picture of a cell phone. They look like that. Those were the pictures of the cell phone. And when we take a look at type 2 diabetes management, the consensus was that the targets were much higher than they are today. And that was because data hadn't been published from the landmark DCCT trial, showing that if you target an A1C closer to 7%, you prevent a lot of complications. And so when we look back at that, we say, wow, 9.4%, that's really high. I can't believe and this was a CDA conference, so everyone is familiar with that. I can't believe we thought this was normal, and then the new normal shifted based on discoveries that were made largely in Canada. So I want you to think about what we're doing now. So objective number 1 is think about what we're doing now. Think about where it's gone wrong. And today I'd ask you to focus on chronic diseases in children. And then the second objective is for you to actually jump ship. So I think the hardest thing to do is to swim upstream, to say, well, everyone's doing this, so that's the way we should be doing it. Instead, I'd like you to say, I'm going to be that first fish to jump out of this pond and start my own pond. Whether you're a clinician or a scientist, and get the next stream going. So, take-home message number 1 is that lifestyle interventions for kids with chronic diseases really don't work. So if you're going to take home a message, last night we had a Café Scientifique at McNally Robinson talking about sitting as the next smoking. When we ask kids to change their diet, when we ask kids to be physically active, when we ask kids to change some of the behaviors that would modify their risk for chronic diseases, no matter what we have tried, it has failed. So, currently, exercise and lifestyle do not work. So, here's an example, and I could have had 6 or 7 different graphs like this. So, for those of you that don't do the clinical epidemiology, this is the results from a meta-analysis where we take a look at a series of interventions. In this case, they were all randomized controlled trials. And we see the effect of the intervention on an outcome of interest. And in this case, it was body mass index, or BMI, in kids. And the question was, what is the value of doing school-based interventions to increase physical activity in an effort to reduce BMI in kids? So can we prevent obesity by delivering interventions in schools? When you pool all the data together, you get a diamond at the bottom, and the space, the position of that diamond on this graph will tell you whether the interventions as a whole worked or whether they didn't work. And in this case, of the 13 interventions, there were a few that worked, one up here and one down here, which I'll talk about later in the talk. But overall, the diamond is right in line with 0, meaning overall school-based interventions don't work on BMI. Now we can take a look at home-based interventions. We can take a look at clinical-based interventions, like I just mentioned, school-based interventions or community-based interventions. Systematic reviews of all the trials that we've done have yielded either really small but statistically meaningful effects or no effects at all. Okay, so for us to think that we can take youth that are living with 240-pound body weights at 15 years of age and get them to a healthy weight status, there's no evidence to suggest that we can do that without bariatric surgery. So we can either say, let's try to tweak these interventions, let's try to keep pushing the same message, which is, if we can just get kids to exercise, if we can just get them to lose weight, we're going to see these beneficial effects. Or we can blow up the whole system and say, let's take a fresh look. So the fresh look at this, which I'm going to argue further on, is to say, let's take a step beyond simple behavior modification and take a look at something that's deeper. Now, I present this because Brandy and Christy were awarded the Article of the Year back in 2013 by the Canadian Pediatric Society for a really nice chart review that they had done. And this is something that Heather and Liz wanted to do for a really long time. And we found that within the Pediatric Endocrinology Clinic, which is referred to as DERCA here, that a number of the youth who are diagnosed with DERCA, a number of the youth that have come in presented with type 2 diabetes were able to successfully manage their glucose to the target range, which is really difficult to do, and keep it there for 12 months. And our conclusion was that for youth that qualify for being treated with lifestyle approaches alone, okay, around 50% of them that did qualify were able to achieve that target A1C and maintain it for 12 months, which was larger than any other group in town. However, if you take a look at the American Academy of Pediatrics guidelines, they say that lifestyle intervention, while it's important as a part of the program, that you should be giving all the kids metformin, because in reality, lifestyle approaches don't really work. And so if you take a look back at our paper that we did publish, and that they did win an award for, if you take a look at the total number, it's actually pretty small. So I think it's around 20% of the kids who come into the pediatric endocrinology clinic and are being managed for hyperglycemia. The number that are able to achieve that target is really, really small, and the number that actually lose weight is even smaller. So currently, there's a bit of I would say a little bit of controversy in this area, because you have large bodies that are saying we have to treat kids with medications, and saying that lifestyle actually doesn't work. And in terms of type 2 diabetes, which is where my interest is, so that's why I'm focusing this talk on that. One of the landmark studies that came out back in 2012 was to try to see what clinical approaches work for preventing kids from treatment failure. So after a newly diagnosed or recently diagnosed type 2 diabetes, they had all the kids managed to target A1C. They followed them for 2 years, and they evaluated the efficacy or the effectiveness of 3 different interventions. Metformin by itself, which improves insulin sensitivity, metformin with rosiglitazone, which also improves insulin sensitivity, and metformin with lifestyle, which would be a personal trainer, and targeted lifestyle approach. So in this case, it was not only a personal trainer, but it was everything in the kitchen sink. So if the kid was given the recommendation, so lose 7% of your body weight, exercise 300 minutes a week, change your dietary components so that they're less glycemically toxic. If they fell off the wagon, there was money there to get them back on the wagon. There was money there to provide them resources to a gym. They had a personal trainer, so it was really expensive. And this graph shows the proportion of adolescents that failed therapy. So they needed insulin to maintain their blood sugars, or that their blood sugars hit a certain target that was considered a failure. So in this case, 8%.
So John, this is Mitch rounds and we're allowed to be talking.
Sure.
Remember, this is a population of children whose A1C was under 8% and their goal was to keep them under 8%. Okay?
This was a
These
population.
were not kids whose A1Cs were 9% or 8.5%, and their goal was 8%. It was not target. And they showed that in a group of children whose A1C, relatively newly diagnosed, because many of them were screened to get in the study, so some were brand new, but it was mean of 14 weeks or something, whose A1C was under 8%, their realistic, real life, I mean, I think it was a great target, was to see if they could keep them there. They were not a target, they were not aiming for target.
But they got them to target. They got the majority of the target. So they had a run-in phase
their
where...
failure rate, no, it was 8%, John. Their definition of failure was unable to keep them at 8%.
Right.
And I think that's a great realistic, because it doesn't matter who you are, what type of diabetes, we know that 7% is very, very hard. So I actually think it was a great target.
So it was a strict target. It was a tough target.
But
also,
it's not the target of 7%. These were kids who were under 8% when they were enrolled, and the objective was, could we keep them in could we keep them there?
Right, but that's not actually the case though. So when they were first enrolled, a lot of them were higher than 7 or 8%. They were all put on metformin. They were brought down to 6%.
They weren't enrolled until they were under 8%.
Correct, but they started. Some of them started in 8, 9%, but they were given metformin until they hit target. Once they hit target,
and
they were
if they
randomized.
didn't, they weren't enrolled.
Right.
So this was a group of children whose A1C was 8% or less, and they had a real life, I think more realistic, can we keep them there?
Right. And so they excluded the kids who couldn't get there with metformin alone. So I think this is sort of our best case scenario. And even in our best case scenario, it did work. Okay? So if we added an intensive lifestyle...
John, what's the definition of glycemic failure then? 8% or 7%?
So that was 8%. In this study, it was 8%.
And I'm not being critical of that. It's, can we keep them reasonable? Were they reasonable, and can we, over time, keep them from deteriorating? Can we keep them reasonable? Maybe it was a real life reasonable.
And 50% of the time, it didn't matter what you gave them, you couldn't do it, which shows something else that we're not going to discuss today. But adding the kitchen sink for a lifestyle intervention, which we could never pay for in the current model, healthcare model, or healthcare system model, didn't work. So in terms of systematic reviews and in terms of large scale, this was the largest trial ever done with youth with type 2 diabetes. It had 700 youth in it. Lifestyle doesn't work. And it was significantly less effective than what we had seen in adults. So why is it not working? So here's why we're obese. Here's why populations are obese. This is a nice, easy to understand graph that a bunch of scientists developed. So it's, I think, purposely complex, right? And some people have actually drawn it. So if you get rid of the bubbles, it even looks more daunting. But it's a very complex condition. A lot of times we say it's just as simple as calories in versus calories out. You just have to eat fewer chips and take the stairs every day. But there are a number of other factors that drive our body weight. And in kids, they're significantly different. So I think as healthcare providers, or as scientists, or as teachers, if we just focus on the exercise and the diet, we're really missing the boat. So first off, it's an extremely complex condition that can't be simplified down to 2 factors. If we take a look at socio-ecological models, so as part of this chair application, they wanted us to develop population-based interventions. So not the kind of interventions that we just described there. And in a socio-ecological model of obesity, the individual's in the center, and each ring represents different layers that potentially affect how you choose to eat or how you choose to be active. So for example, within your own life, your values around certain foods, your values around exercise may be different, right? So having a one-size-fits-all approach doesn't always work. And your family structure might be different. If your family is like Heather's family, and they're all national level athletes, then skiing and cycling just become part of your life. If that's not part of your family, then asking the individual to make a change when the whole family's not supportive of it makes it even more difficult. And each ring represents larger and larger areas that are going to affect your health status, especially around obesity. Now, the majority of the youth that we're seeing in Manitoba that live with chronic disease are Indigenous. And so there's a layer that is not included in that previous one that has been added by Noreen Willows. So this is a very nice paper published by Noreen Willows, Tracy Delormier, and Hanley back in 2012. And they've added a third ring. And that third ring are historical factors that I would also define as adversity. So it's a third layer of complexity. So now we're looking at adolescents who are living with type 2 diabetes or hypertension or other chronic diseases that are suffering from historical trauma or current levels of trauma and racism or transgenerational stress that is over-encompassing all of these things. And so for a child coming into the hospital and living with a chronic disease, and then we're saying, okay, it's just as simple as you got to eat a little less or you got to exercise a little more, and that's going to fix everything. And we don't recognize that a lot of these other factors are influencing their life. I think we're definitely missing the boat. And so if stress is the underlying factor, then I'm going to argue today that resilience should be the centerpiece for addressing the behavior change. And that we forget the simple balance of exercise and diet as the main drivers, but that promoting a strong, healthy child is going to have a better effect than just focusing on the simple one. So for the chair, this is the framework that's going to guide what we do within my lab for the next 5 years. So we put resiliency, and I'll talk about that model. That model is called the Circle of Courage. It was developed by an Indigenous scholar, Dr. Martin Brokenleg. And we've put that as the core foundation for what we're going to do. So within the chair, we have 3 different approaches. One is going to be school-based on reserve. The second one is going to be school-based on and off reserve. And the third one, we're going to try to get a group together around adopting this kind of approach within different clinics, different obesity clinics. So the rings that we've developed are resilience-based rings. So you're going to have individual-based resilience, school or community or family-based resilience, and they're going to be protecting the child within the inside around the adversity that they're currently facing. So the second take-home message, so the first one is that lifestyle doesn't work. And it doesn't work because we're working with kids who are suffering from a significant amount of adversity. So if you have a child that's food insecure, living in an overcrowded home, suffering from generations of trauma, at a high risk for suicide, high rates of depression, high rates of anxiety, why would we just focus on their BMI? It doesn't make sense for them to walk into our clinic and we just put them on the scale and say, we're just going to focus on your height and weight. So we need to address those kind of things first. And there's a lot of work in this area. So there's a really nice resident research project, I think, that was published back in 2002 by Jeffrey Schwimmer, who's now a leading clinician scientist in the area of fatty liver disease, where they took a look at perceived quality of life between healthy weight youth, overweight obese youth, and youth living or treated for cancer. And they found that perceived quality of life is significantly lower in obese youth coming into obese clinics than it is for kids who have been treated with cancer. So there's a lot of social, emotional, and cognitive issues that surround living with a chronic disease. This study, called the ACEs study, argues that adverse early childhood experiences program a child's risk for chronic disease later in life. They disrupt neurodevelopment, they lead to levels of depression, anxiety, stress, that subsequently lead to the adoption of high-risk behaviors and subsequently chronic disease later in life. And so these studies have shown that if you're exposed to early childhood experiences, and some of them are really adverse, like being sexually abused, you're more likely to adopt some of these behaviors and end up with chronic disease. And using some data that we've collected as part of, or that I've been a part of having collected, the Growing Up in Ireland Today study, which is a large prospective cohort study of 20,000 kids. We've started to look at some of these adverse early childhood experiences and see how they affect behaviors in early childhood, and then follow them through adolescence. The majority of these studies have focused on adulthood. Now, if you take a look at, again, we were presenting this at CDA. Dr. Dean presented these stats as the opening keynote lecture for the conference this year. In terms of the youth coming in with type 2 diabetes, 60% live in poverty, 47% have been admitted to psych at some point in their adolescence, 30% haven't completed grade 9, quality of life is low, and a lot of them may be experiencing food insecurity, which is something that we found later on as we started to do some of our school-based work. So another really nice study that's going on here at Mitch is called iCare. There's a group meeting today at 3 to talk about the next version of this. But if you want to go through the protocol that was published last year, Allison and Brandy are the PIs for this. And in the first iteration of this study, they took a look at some of the mental health consequences of living with type 2 diabetes. So we'll just give you some insight into where these kids are. So they filled out a few questionnaires, and those questionnaires were harmonized with the Canadian, the CCHS, Canadian Community Health Survey. And so here we're looking at a total mental health continuum score. So the higher the score, the better your mental health. The lower the score, the worse your mental health. And we're just taking a look at national averages, stratified based on different areas. So we have in blue the Manitoba average, in red the Canadian average. You can see that boys and girls, or men and women, and these are restricted to 15 to 24 years of age, which is around where the cohort group is. So in Canada, youth living with diabetes tend to be a little bit lower than youth living without diabetes. Boys and girls are relatively the same. White and non-white are relatively the same. And the scores are right around 55, but if we take a look at youth living with type 2 diabetes, it's significantly lower than that, suggesting that one of the major complications in this cohort is lower mental health. And if we take a look at distress, it's the same thing, but in the other direction. These kids are all living with significant amounts of distress. So again, reinforcing, and I would say that this is just an example. If we went into a hypertension clinic in the States, or we took a look at the chronic kidney disease clinic by Dr. Dart and her group in nephrology, we would probably see the same thing in terms of mental health. That the kids are living with chronic disease, they're presenting with physiological disease, but mental health issues are at the core. And so in collaboration with the group at the DERCA, we did a qualitative assessment of what's happening in the lives of the kids. So way outside of my area, and something that I didn't think we would ever get into. But the more time you spend with the youth, the more you realize that there are underlying factors that we just can't measure with the tools that we have here at Mitch. So this is one called My Voice. There's another beautiful one that Catherine did in collaboration with Dr. Dean and Sharon Bruce called Storylines, that is available? No, not available.
Not yet.
Not yet? I have seen a really nice
You say poster.
Poster of it, that was beautiful. So, but just trying to get at the contextual experience. So the lived experience of a child living with a chronic disease. In this case, it was youth with type 2 diabetes. So Jackie Dumonte was an undergrad co-op student in my lab for a little while, and she ran this. And Jen Prodiger is doing her postdoc in Sweden, and at the time she was a PhD student with Dr. Becker, who was interested in mixed methods. And so after interviewing clinicians that were working with the youth, the parents of the youth, and the youth, we came up with a framework based on their response to a series of questions around what healthy living means to them and what drives their healthy living behaviors. So things like violence in the school, violence in their neighborhood came up from the youth as a limitation to their ability to do physical activity, for example. Poverty was a common theme all the way through as something that made it very difficult for them to adopt healthy living behaviors, including food insecurity, which I think is a really underappreciated aspect of the life of an obese child. I don't think many people understand that obese kids living in poor areas of Winnipeg aren't eating. So in my own experience, when I moved back here, I needed some experience working with Indigenous youth because I never had. So I volunteered my time at RB Russell to coach the basketball team. And the kids would come into basketball, we'd practice for an hour and a half, and we'd sit down, and we'd always have some kind of food afterwards to keep the guys in. And a lot of those kids, the majority of them were big, big kids. A lot of them said, this is the first thing I've eaten today, right? And now, if you're looking at a kid who's 200 pounds and thinking, they must be eating a ton of food all the time. But I think the food intake is like this. I think there are waves of food intake, and then there are waves of insecurity. Waves of food intake, waves of insecurity. So if a child comes in to our lab and we say, okay, you're 200 pounds, I need you to not eat as much in the next couple of days. And they've just gone through a period where they didn't have any food in the house. I've just lost them, right? They're not gonna listen to me because they're like, you should have asked me whether or not there was actually food in the house because I haven't eaten. So we would call those the social determinants of health, and they're major driving factors identified by everyone, by the clinicians, by the children, and by the parents. The green ones are positive, so supportive relationships. Everyone felt like the better the relationship and the more relationships that they had, the better off they were and the more likely they were to adopt healthy living behaviors. So again, this is a layer outside of the diet and exercise. Trying to create environments where there are those kind of relationships that allow kids to make those healthy living behaviors. And then on the other side, on the parent side, there were perceptions of where that control came. So children forgetting to take their medications, children forgetting that they weren't supposed to drink a certain type of drink. And shame. There's shame on the part of the parents and there's shame on the part of the kids. The media right now chastises. So when we take a look at images of obesity on the news or in the paper, it's never a friendly image, right? It's not someone exercising or someone in a happy environment. It's always a picture of a gut or a picture of someone sitting waiting for a bus and you can see that they're overweight. And so it's not a really nice image. So when kids are coming in, especially for obesity-related chronic conditions, there's a shame that the media blames, there's a lot of blame associated with it. So when kids are coming in with type 2 diabetes, I think, and obesity, I think there's a lot of shame on the part of the parent and a shame on the part of the child that we need to recognize.
John, one thing that's not there that I guess when I was preparing for the CBA talk that I had an aha moment was reading a beautiful paper by Brian Postal, Kathy Cook, and Mike Moffat.
Yes.
It was published in 2010 that suggested that there's a separate culture-specific, not culture, but group-specific layer of determinants of health, which has to do with connectivity to the land, pride in language, pride in ceremony, contact with the healthcare system, i.e. the more you have of the others, the better your health is overall. The more you have contact with the healthcare system as a child, the less healthy, so lower contact with healthcare. But the whole notion of how much they are involved with heritage. And it certainly affected me in the way that I interview, and those kinds of questions now are front and center in getting to know families and talking to families about language in the home and ceremonies and dance classes. Are you involved in dance classes? And I think we perhaps haven't spent much time looking at it. We've never captured it in our own clinic as the amount of pride that they have in their own heritage and the family pride and what the experience in residential school was with their grandparents. So I think that's also something we've learned a lot more recently about, and I encourage people to read the paper by Brian Postal.
Yeah, it comes out a lot in Thomas King's book, The Inconvenient Indian, as well in terms of social policy and things like that. But the land is absolutely part of that. And I think this came up at the last, when we unveiled this, Terry unveiled this, was that we don't have a lot of Indigenous representation in Mitch, and I don't think we have a lot in the hospital as well. And having that other approach here, I think, really makes a big difference. When I go up to Thompson and work with the elementary schools there and the early childhood educators, they're all talking about having outdoor classrooms. They're all talking about reconnecting the kids with the land. At Wapanak School in Thompson, it's Cree everywhere, right? And so they're really starting early to embed that, and the schools have adopted it. I don't see that here in the hospital yet, and I absolutely agree that that's another part of this that should be in there. And then in terms of some other strengths, having a dedicated team clinically that's devoted to this, creating relationships between the team and the patients, having unique clinical knowledge around type 2 diabetes, but maybe also unique cultural knowledge about the needs for Indigenous youth. And so, how do we promote resilience in that setting? So if we know that adversity is cornerstone, and that there was a lot of red on that previous slide, and that red wasn't around the things that we would normally assume are barriers, right? Like, I don't have enough time to exercise. I don't like eating certain kind of foods. We've got to start promoting resilience. And so resilience is thriving in the face of adversity. And I like this picture because it's an example of something beautiful emerging from some pretty significant adversity. And so I think that's the approach. And for this chair, that's the model that we're going to try to promote, is to say, how do we use resilience as a pathway to health? And so we did a pathing ceremony or pathing process with some Indigenous leaders in Manitoba in December to talk about what their vision would be for supporting resilience as a path to health in Indigenous children. And so there are different ways to promote resilience, and it's a psychological concept. A lot of the research has come out of areas where there's a lot of adversity. So the one that comes to mind would be child soldiers. So child soldiers brought into significant stress, living horrendous conditions, and a destruction of their psychology. Some of them are able to make it out and live an otherwise normal life. So trying to understand the concepts that promote resilience is a really key part of what I'm going to try to promote over the next 5 years. And Michael Unger at Dalhousie is an international leader. So he's developed some questionnaires that can be used in Indigenous communities. They've interviewed youth in northern Manitoba, northern Canada, inner city Winnipeg, South Africa, Ukraine, Russia, China. And they've developed questionnaires and tools that we can use to assess what are the determinants of resilience, what builds resilience in kids, and how can we develop interventions to support that. So the model that we've elected to choose within our group is called the Circle of Courage. It was developed, like I said before, by Dr. Martin Brokenleg. He was here in September giving a talk at our childhood obesity conference. His work is not in obesity, not in chronic disease, but we would like to take his model and bring it in as the theory governing what we would do. So actually the belonging should be on the top. What it suggests is that we need to build these 4 areas of a child's well-being before we start addressing things related to chronic disease. So those 4 things are belonging, mastery, independence, and generosity. And they're quite simple. And I'll give you an example of how we tried to build that into a program that we were running here in the inner city. And so as you can see, none of these are necessarily related to chronic disease management. So here's a program called Beating Diabetes Together. It was a small MIDGE grant that we got, I think, 2011, to get pilot data for a randomized trial because we wanted to prove, based on the paper that we had done, that it was possible to develop a program of healthy living that would lead to improved physiological outcomes in youth living with type 2 diabetes. And it was run by the daughter of a former employee within the DERCA, Danielle, who works down at the CRU and is part of our team. And we ran it through the school year, 2 nights a week at RV Russell. And we provided everything, including the kitchen sink and the kitchen, into this program. So we bought curriculum from Yale that had shown that if you follow this curriculum, kids are going to lose weight and it's going to stay off for years. We provided access by driving the kids to the program. We provided them access to the gym. We bought food. We taught kids how to cook. We taught kids how to shop. We had no effect. So after the first year, we saw nothing. And it was hard even getting the kids out. So we had to really adopt our model. But you can see that there are a lot of happy, smiling faces there. because we didn't quit on the program, we kept it going for another year and a half. And I say we, but it was actually Danielle and her team that really drove this. And in the summer, for the last 2 summers, they ran sort of a summer camp. And after the first year, we took a look at it and we said, we got to throw away this Bright Bodies program, because the kids, they get it. The kids knew what to eat. They knew that they needed to exercise, but it just wasn't resonating with them. So we started to change the model, and we started to promote concepts of the circle of courage, and stealthily incorporate healthy living behaviors. So in terms of independence, all the kids got once or twice, they got a certain amount of money. After they had learned what kind of foods were healthy and how to prepare certain types of foods, they were given $50 or $60 to go to Nietzsche Commons, to grocery shop for their family, and to go home and cook a meal. So in this case, we were promoting independence by teaching the kids how to cook some meals, and then have the responsibility of finding the food, bringing it home, and then preparing the meals for their family. The second one was generosity, so doing things for others. This summer, the kids volunteered their time throughout the summer to participate in different activities. How did we actually get the kids to do that? We asked them right at the beginning, what do you want to do this summer? What's going to help you? I want to get a job. I want money. I want to be able to live more independently. How are you going to get a job? You guys are 15, 14 years of age. Well, we could volunteer. So throughout the summer, they chose different volunteer activities that they wanted to do. Last year, they made wreaths and different ornaments that were being sold by R.V. Russell. So they donated their time to that cause. Belonging, everyone got this is actually the I Care hoodie, but everyone feels like they're part of a team. They got a name, they're on Facebook together, they're friends, they talk to each other before and after. When you look at this, you say, well, how can we build this into the hospital? And I think we just have to blow up the model that we have and say, well, if we know this is important and we know this is what kids want, how can we create it in the system that we work? So this was really, really important, is that the kids now had a space to meet and talk, and they didn't feel isolated. There aren't many kids out there who live with chronic disease, despite all the media. If they have a place where they can sit down and talk to each other, and talk about what it's like, and share some of the difficulties, it really makes a world of difference. And then finally, mastery, or mastering a skill. And the way we did that, again, was through teaching them certain skills like cooking. The kids were also involved in presenting their work, so they came to the National Aboriginal Diabetes Association meeting, and they presented their experience living or working within BDT, and mastered that skill. The other really, really great example of mastery came from one of the girls here. 2 of them were sisters, and they were really, really, really shy. And what we wanted to do was build an environment where they could show us that they were masters of something, right? Because I think a lot of teenagers don't feel like they contribute enough. So one of the girls came up and we said, today what we're going to do, it's not about healthy living, you just have to show us what you're good at. One of the boys was good at football, he was going to show us that. Someone else was good at gardening because we were working in the gardening program, they're going to show us that. But one girl who rarely spoke, she was good at drawing, and every day she'd have her sketch pad out. And so she came up, and we said, can you just teach us how to draw, because none of us can. And her picture that she drew is up in our office right now, but she sat down and taught all of us how to draw a flower. And it was amazing. She's a remarkable artist. But what happened after that was that everyone complimented her. Everyone did worse than she did, so she realized she was better than the rest of us. Mine was terrible little stick marks. But all of a sudden it built this self-esteem and this self-efficacy in her that said, hey, I can do that. So the next time she came back, her hair was pulled back, you could see her face, she was smiling, she was engaging with other youth, participating in the program, she was bought in. Why? Because I think we demonstrated that she was able to master something and that she was good at something. And that allowed her to say, okay, maybe I can get involved. And that changed the focus. And for the rest of the program, she just evolved and things worked out really well. So, what else have we done this? We published this paper this year on a program called Rec and Read, or AYP. It was developed by Joni Hallis in the Faculty of Kinesiology and currently led by Indigenous scholar Heather McRae, whose office is actually on Selkirk. at the Bill Norrie Center. And within Mitch, you guys would know Pinar. She's a master's student that's been involved in taking this forward. And so we published this looking at, does this Circle of Courage model work for attenuating weight gain and other risk factors for type 2 diabetes in youth living on reserve? And we did that we piloted in Garden Hill, and we got a CIHR grant last year to expand it out to 5 different communities. So Rec and Read is about building on the strengths of youth. The framework is the Circle of Courage. We engage high school students to lead after-school programs for elementary school students. So they deliver the program. It's really cheap because we don't have to hire people to do it. It's very sustainable because as the grade 4 students end up moving throughout their school years, they come back as mentors. And it's empowering, so it's their own program. It started in Garden Hill 5 years ago. We started with 7 mentors. This year we had 65 mentors. We had too many. Why? Because it was the 5th year. And all the original grade 4s were now in grade 9, and they were coming back to come back as mentors. They've published the model for this. The other strength of this is it's an Indigenous-based model, focusing on the strengths of youth. Belonging, the kids make their own t-shirts, they design their own program, they get their friends involved, they run the whole thing, it's their own program. This is them doing a sharing circle at the end of each day to talk about what worked and what didn't. It worked. Sorry, I missed the slide there. So what did we find? The program is run one day after school for a period of 5 months. It runs every week. Currently, we're in Garden Hill, Thompson, Woboden, Saugeen, and Sandy Bay First Nations. We're touching the lives of about 500 kids currently. In the pilot work, we found that kids who participated in the program had slight reductions in their BMI Z-score and significant reductions in their waist circumference. The kids, in terms of models of KT, the kids also own the data and they own the program. So we've been running this program for 5 years. We've only had 1 publication come out of it because the data is not ours. The data is owned and operated by the community. I don't know if you've seen their Mentor Voices grand rounds, but they've been here once and they've presented once down at in the Faculty of Pharmacy, where we bring all the mentors down once a year and they share their experience about what it's like to be a mentor in the program. And they're the first to present their data before we do. In terms of generosity, a really nice paper came out in 2013 out of BC from Edith Chen, and it doesn't get enough press, I think. They randomized kids to teenagers to either volunteering their time or to another program. So volunteering their time, they were, just like we were doing in the AYMP program, they would work with youth after school. And in this case, they just measured the physiology of the teenagers who were volunteering their time. And over the course of a school year, the teenagers that volunteered their time had drops in their IL-6, drops in their CRP, and gained less weight than kids that didn't. So overall, just volunteering their time or contributing to generosity led to health benefits in those kids without them participating in any other real exercise or dietary interventions. And we saw the same thing with another study called Healthy Buddies, where we collaborated with Rob Santos, who I'll show you in a minute. Anita's still working in my lab, and this was part of Jackie's co-op program. Paul MacArthur's now doing his MPH in BC. Or they did a cluster randomized trial in 20 schools within Manitoba. The goal for the province of Manitoba was to see whether or not this program worked. And I'm sure you've seen a lot of this before, but what's really interesting is in the older kids. So Healthy Buddies was a program that was delivered in the classroom by older students to younger students. The older students who delivered the program, they saw the same benefits as the younger kids did. So they saw a reduction in their waist circumference, reduction in their BMI, and improvements in their healthy living knowledge. That happened to them just by volunteering their time as mentors. Now we take a look at the iCare project as another model. This is again youth with type 2 diabetes. They filled out a resiliency questionnaire as part of their annual research visits here, and you can see that their A1C, which is a marker of their blood sugar control, is lower the more that they feel they have a sense of mastery in their life. So the more resilient they are, the lower their A1C is. And if we take a look at their overall resiliency score, it's the same thing. The more resilient they're perceived to be based on that questionnaire, the lower their A1Cs. So what can you do? So the first one would be, if you're a clinician, take a look at some of these tools. So a conversation card is putting the discussion in the hands of the kids. So the Canadian Obesity Network has developed a set of cards that you can use in your clinical setting, where when the kids come into a clinic, they tell you what they want to talk about. So they fish through the cards, they find topics that are on the cards that they relate to them, that they think are important, and you sit down and say, what are we going to talk about today, guys? And they put it in there. And so if you want to develop your own set of cards, you could develop it based on anything that you think is important for the group that you're working with. The second one is, don't be afraid to go into areas that you're not traditionally trained in. So I'm going to spend time in Halifax this year, going to this conference, looking at pathways to resilience, and spending time with experts in the area to see what can we do in the area of chronic disease and resilience, and how can resilience be embedded into chronic disease management in kids. And then finally, don't stay in the same. So the most dangerous phrase in English language is, we've always done it this way. So get out of what's comfortable and try to get down a path that you think is uncomfortable. What is the most famous line from this movie? That's the most famous line. But what's the most poignant line in this movie?
What was the most famous one?
There's no crying in baseball.
Oh.
So she made a mistake and started crying, and then Tom Hanks was like, there's no crying in baseball. Screaming at her. But that's not actually the most famous line. You know what the most famous line is? Gina Davis was going to quit. Gina Davis was the best player on the team. She's a back catcher. She's like, I'm out of here. And Tom Hanks is like, why are you leaving? She goes, it's too hard. It's too hard. The travel's too hard. I've got a family. I've got a life. It's just too hard. And Tom Hanks says,
if it was hard, everyone would do it.
if it's hard,
It's easy.
right. It's the hard that makes it special. If it wasn't hard, everyone would do it, right? And so working in the area of chronic disease, working with Indigenous youth is hard. It's very, very hard. But it's that difficulty that makes it special. And getting involved in that and dedicating yourself to that makes you special. And so opening your mind to some of these other areas, I think, makes it even more special. So it's the hard that makes it special. This is a beautiful sign that's up in the school in Woboden. It's about youth living with different conditions. If you think my hands are full, you should see my heart. And I think that's how you should be looking at kids when they come in. Despite the adversity, despite the distress that they're living in, there is something very special inside that each kid has that we can bring out, as long as we take the time to pay attention to it. So, what should you do? Focus on the next generation. Don't focus on exercise. Take a look at the whole child when they come in. Everyone has that responsibility. If a kid came in with all of these conditions, how would you react, whether you were a clinician, healthcare professional or not? Try to learn what you can about resilience. I think the circle of courage is the way to go, but there are different paths that you can decide to take. And that's it. I've worked with a lot of different people over the last 9 years that I've been here. These three were the ones who got us rolling in Garden Hill and helped me carve a path into Indigenous health research in kids. Larry Wood is the ADI worker in Garden Hill.
Aboriginal Diabetes Initiative.
Yes, Aboriginal Diabetes Initiative worker. He's funded, that's funded through the federal government, and he's been there. He's probably one of the longest running ADI workers in his position that I'm aware of, and I told you he's been there forever. Mary Wood, she started with us in our first couple of years when we got this fitness center started. Catherine was actually there opening day for this, and Alma McKay. They both got some healthy living programs running in Garden Hill First Nation, and they got us in to do the youth-based program. They've been instrumental. None of this could be done without the DREAM team, which is a fantastic group of researchers here at Mitch that span the continuum of cell science to epidemiology and focused on this area. And then finally, everyone in my lab has been really instrumental in collecting all that data. I just do the talks. Everyone else does all the work. And our funding agencies. So thank you very much. apologize, Chris wasn't. Questions, thoughts?
Joan, what did you do, or what did Pinar do to manage the fact that you had, what was it, 65 people now that wanted to be part of the youth leader? And you said you had too many, because sometimes if you grow something and they can't participate in something that their expectations were, how did you manage that? Because you don't want disappointment.
Right. So that was difficult. And what we relied on throughout, what we do here is something called community-based participatory action research. So we can't really say. So we work as a collective, and usually the schools have better ideas because they're used to that. So the schools had to decide what they would do. So either create other opportunities for the kids. Last year what they did is there was a sign-up. So the first 15 kids in got to go, and then the next 15 will get to go the next week. And currently we're not at that level in other schools, so Garden Hill and the teachers have just had to figure out how to do it on their own. But having that social capital is really, it's extraordinary.
Excellent overview, John, and congratulations to all the work. I'm just wondering, when a long time ago we were in that community in Garden Hill looking at lung health issues, it took us a while to get into the community, and we found out later actually that their motivation was different from ours. They were particularly interested in aspects of road dust and lung health. We were more interested in the effect of lung infections long-term on lung health. So when you say they own the data, do they give you an indication of what they're interested, what their questions are?
Yeah, so we did a project. The very first project we did was photo voice. And this is an issue that we ran into that we couldn't overcome. So when we asked you, so we did it. Photo voice is a project of empowering individuals to tell us what their priorities are. And actually, Christy's not here today, but the new KT platform at CIHR, they have the task of creating some of these, of engaging patients and determining priorities. And actually, the AMC now has a group that's focused on that as well. It's called Patient Engagement Partners for Engagement and Knowledge Exchange. And so they can help with that. So within our photo voice group, photo voice project, we had kids, adults, and older adults take pictures of their community and talk about health. All three had different things that they wanted to focus on. What do you think the kids wanted? What was the #1 barrier to health for children, perceived by children?
Safety?
Yes. How so? What did they take pictures of? 90% of the pictures were all the same. What did they take pictures of? So safety is the answer, but what were the pictures reflecting? Gang symbols. Gangs. So it was all about gangs. Gangs and a bit of drugs. So in that case, it was difficult. Like, we didn't know what to do. That's not my expertise, right? And so it had to be a partnership. We went through a few different cycles of, we came in with something we wanted to do and it just kept failing. And finally, someone came in and said, you got to focus on the kids. We believe in multiple generations and starting young. So one of the teachers, and actually Bruce Martin talked about this Reading Buddies program. And that sort of got the ball rolling on the peer mentoring program. But it was a lot of back and forth with the community. And currently, I would say you need to try to align your priorities, or create a project where both the community and the research priorities get addressed. But we couldn't address the safety issues. We could just share that with Larry and the group there.
John, you mentioned a fair bit about the beginning of throwing out all the old ways at Children's Hospital and doing more of this at the Children's Hospital. My own sense is that the communities are working hard to create programs on the ground. And I wonder if in a 10-year plan, a 20-year plan for the hospital, it would be supporting community activities and knowing about the community activities broadly and supporting them in talking to the kids about them and asking how much involved they are as opposed to healthcare providers feeling like we have to do it. And I'm wondering if that isn't something that would resonate with people. I have the sense that a lot of healthcare providers really struggle because they feel so helpless and can't do anything. And maybe that's okay.
Right.
In the sense of, but what we could do is be much more knowledgeable and much more supportive of the activities that need sustainability and that the kids really relate to and are showing sign of increasing confidence and have elements of the circle of courage.
Yeah, and I see it as maybe a balance between the two. So if I was going to use like a sports analogy, that a defenseman in soccer is not going to be able to do the same thing as a forward in soccer. But the coach will change the game and say, as a group, this is our new approach to scoring goals and winning. So I know that your skills are as a defenseman, but you're going to have to adapt it so that the entire team works together and we're all kind of on the same page. So not to say that you have to do the mental health piece, but that everyone recognizes that the overall goal is to go in this direction so that your skills are assembled in a way that it's circular. The whole group is moving. It's a team effort. It's not just supporting what's happening in a community, but feeling like you're part of the team as well.
Again, I think people struggle in some of the situations like that where the priority of the healthcare provider that has that child in front of them is the disease in which they're seeing them for. But in actual fact, the mental health issues and some of the other issues are much more important in that child's life. So it's hard for people in clinic who have a medical expertise, be whatever health professional they are, to say, we're not going to achieve the ultimate target that we would have for our disease, be it asthma, bronchiectasis, diabetes, whatever else we have in the room, because the goal in this child is to provide supports for their mental health, because that's where it really needs to be, and we need to kind of back off our standard of care, and that's very hard to do.
Yeah, and I just see it as kind of shifting the way it works, because I go back to a powerful person in my area, Jean-Pierre Desprez, who was looking at who delivers the best health messages. Is it the expert, so around physical activity, is it the physical activity expert that has the most impact on a patient when delivering the message, or is it the physician? And it always came back to the physician. The white coat and the stethoscope come with a lot of power and can have a really big effect. And so that's where I think all of us, regardless of where we are, if we have that circle of courage in the back of our mind, I think it can make a difference. So down the road, we assembled a group, and I think doing a little trial in obesity clinics around standard of care versus circle of courage care and seeing which is different would be an interest of mine.
And that may not be in a clinic.
Might not be in a clinic. Could be in a community, yeah. So we'll see. Thanks.
Great.
All right, thank you very much.